Greetings from the Lou. I'm from St. Louis and I'm proud. If y'all, it's 50 years of hip hop, so I have to honor that heritage with Nelly, right? So I'm from the Lou and I'm proud. I'd also like to say big ups to all of those St. Louisans that are here in the audience. A big thank you to the community chair of my governance board for my lab, Ms. Stephanie Griffin. And then a big shout out to Ms. Wright, who just shared stories with me about City Hospital number 2 here in St. Louis that had a tremendous history which is linked to disparities. And to my friend, Consuelo Wilkins, Dr. Wilkins, it is always an honor and privilege to see you. We were training at the same time here at WashU, we won't say how long ago, just yesterday. And so, so thank you to my mentor, Dr. Morris, for giving me place and time. And then to my mentee, Dr. Issa Mohammed. Issa, you have a tall task ahead of you, my friend, and we have your back. All right, so the title of my talk is Enhancing Participation by Minoritized Groups in Alzheimer's Disease and Related Dementia Research. And what do I hit? Do I just hit? Oh, the big green button? See, I wasn't paying it. Did it move? Oh, the big green button. See, I'm dyslexic, y'all, so sometimes I don't pay attention. All right, so these are my disclosures, and I'm happy to talk about my disclosures after the talk. So my objectives are an acronym for NOW. I'm going to describe some of the nuances of health disparities as they relate to brain health in my local community, which is my hometown. I'm also going to talk a little bit about opportunities we have to address brain health disparities. And then we're also hoping through the course of this conference and even the course of this dialogue is to foster conversations that center on the willingness to increase brain health equity. So I'm going to start with a quote from the poet Audre Lorde. "In our world, divided and conquer must become define and empower. So when we build bidirectional research partnerships, we must think about how do we empower our community to have as much say and voice in these conversations." And I will say I made a mistake, and I'll own up to it, because I did not give voice when I was designing this talk to my community partners. Now, granted, many of us in academia, we come to the stage, we come to the podium, and we don't always think about that. But they have as much skin in the game as we do as we try to move towards emeritus. So my challenge to you is to think about that now and how you will engage your community partners and patient partners and caregiver partners and research partners in these dialogues. So I'm going to talk a little bit about the epi of ADRD. So this is very relevant to me, is Alzheimer's disease and related dementia hit our home front with my father's best friend living with a diagnosis, and that's Stephanie Griffin's dad. And I'm very thankful that I called him my uncle, because black folks have a lot of aunts and uncles, so I called him my Uncle Ronald. And my Uncle Ronald actually donated his brain to the ADRC. He was a long-term MAP participant, and Stephanie continues his legacy by working in our community by having the largest African-American caregiver support group, and she's even partnered with our sorority, Alpha Kappa Alpha Sorority Incorporated, as well as another organization that we're both active in, the Links Incorporated, to raise awareness with other communities about Alzheimer's disease. And without her vision, much of this work would not happen here locally. I am also a caregiver of my mom, and many of you all know my mother is actually in the hospital, so I've been stepping out to talk to her care team, and she lives on with some brain health concerns as well, and she told me do not come to the hospital until after I give this talk and until after this conference is over, because she's still my mama. And then I stand on the shoulders of my father, and today is the anniversary of his passing. He was a longtime health advocate, health equity leader, health commissioner in St. Louis and both Illinois, and so I stand on his shoulders today. So for me, this is about legacy. So my reason, as my colleague said, is not about the numbers. And I'm an epidemiologist, so I count and sort really well. But it is about increasing health equity. So when we think about the epidemiology of Alzheimer's disease and related dementia in African Americans, you all have heard the numbers, you know the numbers, that non-Hispanic Blacks and Hispanic and Latin older adults are more likely to have an ADRD diagnosis that is late stage than our white counterparts. We know that there are some differences that influence these diagnoses in these communities. And a lot of times we don't talk about those social determinants and structural determinants of health that really impact those differences. In Medicare recipients, we know that those that are 65 and older who are Black are diagnosed about 13%, almost 14% more, about 14% of African Americans who live on Medicare or African American live with a diagnosis, and about 10%, a little over 10% for white Americans, and about a little over 12% for Hispanic and Latin community. But the burden of Alzheimer's disease and related dementia is highest among persons of color. Dr. Wilkins mentioned these numbers earlier, and some of my other colleagues have mentioned them as well. So the Knight Alzheimer's Disease Research Center, which was founded in 1985, and at that time, we were one of 10 ADRCs. So in 1985, I was 11, living here in St. Louis. And so, as you can see, we are led by multiple research cores. And the Health Disparities and Equity Core was established by Dr. Morris in 2020 with me as the inaugural lead. So again, y'all like quotes because it keeps me honest. So Desmond Tutu said that my humanity is bound to yours, for we can only be human together. So if we come to this place of academic medicine and biomedical research and thinking about ways to increase health equity using a community-engaged research lens from the bench to the bedside, to the community, to the public, to patients, to all of the things combined, we must remember that we are human first. And in our humanity, we all come to these places with a variety of opportunities that we have to be more bidirectional and multidirectional in this ask. This means thinking about social determinants of health that are experienced by our community that are related to Alzheimer's disease and related dementia. This means owning up to the historical underpinnings of bad science. So we live in a space of everyday racism and discrimination. Missouri was a slave state. The Dred Scott case was tried here. That is not lost. City Hospital number 2 was one of the only places in the city of St. Louis where Black families could receive care because they could not receive care here at this institution. My father was born in City Hospital number 2 in 1941. About 10 months later, my other grandmother was able to give birth here at Barnes Hospital to my mom. So what happened in that 10-month period? I don't know, because my grandmothers are not here to tell me. But we do know that the people that we are caring for, that are living every day with a diagnosis of Alzheimer's and disease and dementia, may have experienced some form of discrimination. We also know that lack of access to appropriate and quality care impacts whether or not one has the wellness and the resources that they need in order to navigate the health arena that we call healthcare here in the U.S. We also have the remembrance of misdiagnosis that often happen, and many of you may have stories of misdiagnosis within your own families and within your own lives as well, and how those diagnoses impact whether or not we test the systems which are providing care. And those systems are also often the systems that do research. We also have the remembrance of myths that lead to lack of access to care. Dr. Wilkins mentioned several of those earlier, so I will not expound because she did a beautiful job. So why do we measure race? We know that race is a social construct, but our government agencies and insurance companies measure it. And if this is the benchmark in which they use, then we also need to make sure that we are cognizant of this social construct being measured. We know that race and ethnic health disparities exist. Data don't lie, people do. So we know that. We know that differences in healthcare are real, and many of those differences in care have nothing to do about how much we have in our bank account. Maybe it does, sometimes it does, and sometimes it doesn't, right, Shannon? It also may be impacted by our gender identity and expression. It also may be impacted by how people perceive us to be based on our skin tone. We know that stereotypes, bias, and prejudice and clinical uncertainty are also real. So when we think about diversity in healthcare, minority populations often desire healthcare providers who understand their ethnic or racial backgrounds. They want to see people that understands who they are and their lived experiences. So let's see, Gina, we both get invited back. We'll get invited back. Okay. And we have to give their experiences a place to be told. They need to share those with us, and we need to listen. We need to be willing to hear the stories of discrimination, and that it's not surprising that non-white racial and ethnic populations often feel left out when the conversation related to Alzheimer's disease and related dementia and care providers is discussed. We must think about how to be more culturally appropriate and even taking on a lens of cultural intelligence when we begin these dialogues. We must think about responses from surveys there being a strong desire for dementia healthcare providers who understand those differences related to race and ethnic backgrounds, but many survey responders say they don't have access to providers who look like them. As we often think about the report from the Alzheimer's Association, which stated that 92% of Native Americans say they want dementia healthcare providers who understand their ethnic and cultural backgrounds, yet only 47% have confidence that they are currently have even a little bit of access to them. And this is found similarly to those of us who self-identify as being Black or across the African diaspora, our Hispanic and Latin or Latine brothers and sisters, and even Asian Americans as well. So participants of color often want to make sure that their lived experiences are being reflected in the care they received. So when I came to WashU, I failed. John, I failed on something. And you walked me through that failure. I lost my entire research team when I started. Do you know why? And I don't lie about it, because we have to own up to failing forward. Because I was not thinking about the income that 2 of my first team members needed in order to support their families. One was offered a job paying double what I was paying at WashU in industry. And about, 4 months later? About 4 months later, the other left for another job that was going to be paying like $30,000 more. But yet in academic medicine, we often say that it is a privilege for those people to work at our institutions without thinking about a livable wage. So I changed my model. And as you can see from this team, you all have met many of my team members from my lab and the Health Disparities and Equity Core. So big ups to, because again, it's hip hop. Big up to my team, Peaches Clark, Marilyn Wilson, Dottie McDowell, who spends time in both with me, and also in our ORCOR, Yvonne Hughes, David Bradford, and Maribel Shabowski. We have a team that comes from the community, that is reflective of the community, that understands the community, and that will fight me when I forget it. When I lose insight, they keep me honest. And for that, I am thankful. So the Health Disparities and Equity Core has 3 main goals. Our first goal is to increase community-engaged research opportunities to address health disparities and to facilitate recruitment, and it's not just recruitment, but we also do health promotion, health engagement, bi-directional conversations. We often have written grants, written letters, and provided resources without an ask back to our community partners to make sure that we are in those spaces and we live in those spaces. We also provide education and training on health disparities and health equity to learners both internally and externally, and learners can be any of us. We are all learners because we are still living. We partner with the Knight ADRC leadership to increase workforce diversity, equity, inclusion, and belonging as well. After I got started, John and I sat down and said, what grant do I want to write? So I wrote an R24, but we thought that it was very important that I take a step back because I hadn't lived in St. Louis in 19 years. And I wanted to make sure just me coming home to visit is one thing, but me working in the space in which I love is another thing. We wanted to identify the needs related to generalizability in our local area. We also sought advice from the African American Advisory Board, and I'm thankful for the Advisory Board for their help, as well as our Institute for Clinical and Translational Science. And we used actually a model that Dr. Wilkins made famous, which was the Community Engaged Research Studio, for which her team trained me in when I was still on faculty at Mayo Clinic. Through those studios, we learned that our community partners and patient and caregiver partners thought that we needed to create a governance board that would also glean on some other areas of needs related to our local community, not only related to race and racism, but also thinking about socioeconomic status, also thinking about disability and diversities, and I live with neurodiversity myself, so making sure that we kept those things in sight. We have recommendations from those studios where they said that we needed to make sure that we were culturally appropriate, that we acknowledged mistrust in order to build trust, that the incentives that we were going to be offering were reflected what the community needs. It was one thing to give a meal, but also think about transportation, babysitting, and the like. Also thinking about access, and then what times of day were we going to be and where would we be conducting our work. And so collaborating with local churches and other faith-based communities, local physicians, and even partnering with organizations, not only in the Alzheimer's disease space, but also Parkinson's disease. So this led to my first R grant, which is, this is the title of the grant, the COEQUAL Registry, creating opportunities to increase health equity and equality for persons at risk for Alzheimer's disease and related dementia. And COEQUAL is one word, it is not hyphenated, and we chose this word in order to think about not only equity, but also equality. And no, I'm not changing the name of it because people have asked. So our COEQUAL research team is listed here. And I also wanted to make sure that I honored those staff members that have made transitions off of our team. Dr. Whitney Postman, who is also listed as a co-investigator at the time that I did these slides. Dr. Postman was in the process of transitioning to another institution, and her research, one of our research partners, Dr. Selena Washington, has since joined us. So our first aim is to identify and enhance current practices and resources to promote high-yield recruitment, enrollment, and retention of underrepresented participants into Alzheimer's disease research. So we created our governance board. We also plan to do community listening sessions, which use a scientific cafe model for which I've used in the past, and we call those brain aging cafes. And through that, we also have a pre and a post survey design for those listening sessions to find out what people know about Alzheimer's disease and related dementia, as well as research registries, and well as accessing information around the barriers and opportunities for engaging our local community in those bidirectional dialogues. We have since collected data through that cafe model and the community survey, and we are now in the process, along with my partner, Dr. Jessica Mazursky, looking at and my other research partner, Dr. Kenji Zong, how to analyze the data that we received from the cafe. And so I'll share some of that today. And this also led to the vision of what the registry would look like. And we are now in the process, as we're ready to analyze the data, of thinking about how do we share the findings locally with our partners here, and some of them are here in the audience, so that they can use the data for their organization so it doesn't just live within scientific journals, which means nothing for community engagement and change. How am I doing on time?
About 7 minutes.
Okay. All right, so I'm doing pretty good. All right, so Through the cafe model, we told NIH we were going to talk to, I believe, 150 people. Well, after it got started, guess what happened? My mama's friends, many of which are my sorors, many of which are my link sisters, many of them, and actually one is in the audience today, it's good to see you, Miss Julia, as well, said to me, baby, we need to be going out to more places. So I looked at the budget, and I said, okay, if the community is asking, then I need to shift. And so we were able to shift and recruit more than double what we told the NIH we wanted to talk to. We have hosted, I believe, is it 12? We've hosted 12 cafes. We've done these cafes in churches and community centers and apartment complexes at the, y'all should see. My team has been amazing because they've been nights and weekends as well. Whenever the community says they want them and the time that they want, then we show up. So we've talked to 306 people, over 90% of them self-identify across the African diaspora, with most saying that they are Black. We had 10% that are Hispanic and Latin, and the age range is about 68 years in terms of the mean, with the youngest being 46 years and the oldest being 96. We do need to do a little bit more effort as it comes to working with those that identify as being men or across the other gender identities, because we did have 78% that identify as being women. And then 65% said that they were interested in learning more about our registry once we launched. Our second aim is we are working directly with Dr. Katina O'Leary from Health Literacy Media and her team. And Health HLM, as we call it, is globally the largest health literacy nonprofit organization. And they are working with us to review materials that have been submitted by many of you to NIA ADOR to see if those materials can be useful within our local community, and if we can change some of them without reinventing the wheel, in terms of making sure that they are culturally appropriate for use within our population here locally. So we are developing a checklist, or kind of like a rubric, with HLN and our community advisory board, or our governance board, to think about the culturally appropriateness of those materials, applying those checklists to revise the materials, and then we plan to share those materials broadly here locally, as well as with each of you if you're interested, as well as back to NIA. Our second goal was to launch and establish and implement the COEQUAL registry here locally within the St. Louis metropolitan area. And our goal, I don't know what I was thinking, but I said I wanted to recruit 2,000 people. I really don't know but you know what? That's okay, because we were in the midst of COVID. And that's okay. And I'm learning, right? So, but we have launched. And the first thing that we wanted to do was engagement. And so we have worked directly with the ORCOR, which is led by Andre Denny, who you all have met, the African American Advisory Board, and our governance board, as well as through the Brain Aging Cafes, to start thinking about recruitments and opportunities for expanding our research efforts to engage more locally. And I have on here 100 miles, but we have since expanded to that. And so one of our board members is here who represents the rural community, Ms. Hunter. We've expanded those efforts based on feedback we received and by conducting more studios. So we are also looking at WashU and our health system for internal resources. So we're working directly with the Institute of Clinical and Translational Science, which is WashU CTSA, as well as the Greater Plains Collaborative, which is a PCORI-funded project to think about how we can engage other internal resources around connecting with the community, especially patients and caregivers. And we're working very closely with our Prevention Research Center, which is CDC funded. I have a CDC grant that I'm not mentioning today, and the Institute of Public Health within WashU, and then the Harvey Friedman Center for Aging, as well as the patient portal, which is called MyChart. We have since expanded to other external resources by working with several medical societies, a variety of spiritual and faith-based groups, because we know that everyone is not a Christian, and thinking ahead as well. So just a little bit of data. At the time that I did these slides, we had 178 people. We now have, what, 197? So we're about 10% of where we need to be. Most are African American. We do have a small collection that is Hispanic. And over a third have less than college college graduates, with a little over half making less than $35,000 a year. Most of our participants are retired. And then we did do the 88, and we found that many of them, thank you, John. Okay, have an 88 score of 0 to 1, and then most of our participants did not have study partners. That's something y'all need to think about as well. So I'm gonna leave you with this. Prejudice is the burden that confuses the past and threatens the future and renders the present inaccessible. That's Maya Angelou. So we have to be willing to move forward with next steps. So we are going to continue our efforts for engaging in recruitment through COEQUAL. We are thinking about how do we disseminate what we learn and what that means to our community partners and the works they want to do, while we think about opportunities to have our community partners more engaged with a voice at the table. So the time is now. We must acknowledge that disparities exist. We must discuss our fear with thinking about historical underpinnings of bad science that impact marginalized communities. We must consider data analysis and interpretation of those results in the context of racism and determine ways we can increase health equity. So thank you. So remember, being seen, heard, believed, plus acknowledged helps us to build bridges that repair the pain that many have experienced related to our identities and truth, which ultimately increases wellness. Thank you so much.